Welcome to our training module, Recognizing Skin Lesions. My name is Greg Allen. I prepared this with Christina and Lizzie. We are from St. Catherine's PA program, and we thank you for taking the time out of your day to learn about skin lesions. We anticipate that this will not take long to complete. It should be about 20 to 30 minutes of time. You've obviously already taken a pretest. We will ask you to take a pretest after you have completed this training. Our learning objectives are pretty simple. Skin lesions are very common, and fortunately for everyone, the majority of them are benign or not concerning for cancer. Obviously, the lesions you looked at in your pretest, I'm sure you thought all of these looked terrible, but in fact, some of them were, but most of them are not. And through this training, we're going to provide you with the insight of how to be able to tell the difference. But this is also a training for us as well. When we looked into training lay people or hairstylists such as yourself to recognize skin lesions, we realize that nobody in the nation is doing this, although there has been a recommendation from the National Institute of Health to design something like what we've done today. We wanted to try this, and through your participation and your feedback that you can provide us will allow us to know whether or not this is an effective means of bringing awareness to skin cancer. So we want you on our team. We obviously are trained medical providers, but we want you because we think that we can train you how to recognize these lesions as well. You are in a very unique position in that you see portions of people's bodies that are not commonly seen, meaning those areas underneath their hair. And we learned all of this in just a few lectures in PA school, and we think that through this training module, we can get you to the place that you're able to recognize them as well. So it's a couple of definitions before we get started. So a lesion is any abnormal change in skin or really in any structure of an organ, and skin is the organ we're going to be talking about, and it's due to injury or disease. So anytime we'll say lesion, growth, we'll use them interchangeably, but a lesion means just basically any abnormal change. Actinic means changes to the skin that are produced by UV light or UV radiation. Sebaceous gland is a small gland in the skin that produces a lubricating oil. You have a lot of them in your hair, underneath your arms. Seborrheic is an overactivity of a sebaceous gland, and you can get crusting and oily scales on your skin. And keratosis is a condition where you have hardening on the top layer of your skin. Some more definitions. A nevus or a nevi are moles or moles. We'll use those interchangeably. Melanoma is a specific tumor of skin cells, and it's the melanocytes that are actually malignant, and it is by far the most serious form of skin cancer. Malignant means cancerous, benign means non-cancerous. So just a little bit of background. Scalp melanoma is typically recognized in the later stages, and because of that, it has a worse outlook than other melanomas that are typically found in more visible parts of the body. The National Institute of Health has recognized that teaching hairstylists to recognize suspicious lesions could potentially increase early recognition of melanoma, which would improve outlook and the prognosis for patients with melanoma. In fact, in the study of 74 hairstylists in Pennsylvania, 79% reported having seen suspicious lesions on their clients. And in another study, they looked at hairstylists, up to 50% were interested in learning more about skin cancer recognition so that they could make a recommendation to their client if they saw something suspicious. So let's talk about the most common types of skin lesions. A mole or a nevus, or if there's multiple ones, a nevi, obviously you probably are very familiar with those, but what makes a mole turn to melanoma? What's make those different? And obviously melanoma, and we're going to get to that in a second as far as how to be able to differentiate between the two. There's also things that are precancerous, like actinic keratosis, and then there's actual slow-growing cancers of the skin called basal cell carcinoma and squamous cell carcinoma. And there's also things that look like they're really bad, but in fact are just benign growths, and those are called seborrheic keratosis. So let's first talk about what's normal. So a nevus or a mole are benign growths. Some of them you're born with, some of them you develop over time. And they usually are not anything to be concerned about. In fact, if you look at the pictures here, you can see blue nevi, which are just a blue mole or very darkly pigmented mole. As you note in the picture, they can be raised, they can be dark, they can look bad, but that doesn't make them cancerous. But notice that the color is consistent throughout the mole, and we'll get to why that's important here in a second. Here's some more pictures of just benign moles or non-cancerous, not to be concerned about. As you can see, some of them look like they would be, some of them are kind of large, some of them look like they might be concerning, but in fact, everything about these moles is fine. And I'll compare and contrast here in a second when we start looking at more of the cancerous lesions and how they're different than the ones we're looking at now. But if I could point one thing out, you notice that in the pictures, the color is pretty consistent. Even though there are different colors of moles here, the color throughout the mole is very consistent. The border is relatively consistent on all of them as well. Also, you'll notice raised moles, and you'll notice these in the head and scalp as well as on the face, and these are completely normal. So again, you'll see these. They may look like tumors or tumor growing on the skin, when in fact they're completely normal, benign moles. So what is melanoma? So melanoma is the most serious type of skin cancer. It develops in the cells that produce the color of the skin, or it's called the melanin. And those cells are called melanocytes. Their 5-year survival range is from 50 to 100%, depending upon the extent of the disease. And catching this early is key to survival. The problem with melanoma is that it becomes metastatic very quickly, and when it is metastatic, it's invariably fatal. So catching it early, where before it becomes metastatic, allows a physician to cut it off the body. And if you cut it off the body, you can get rid of it. So it's one of those things that early detection results in an early intervention, or an early excisional biopsy, as we call them in medicine. And that excisional biopsy typically is curative. So it's something that, again, if a person is made aware of this and they see their doctor quickly, the prognosis is quite well. If they don't see it quickly and it's something that allows to stay on their body for quite some time, the prognosis is quite poor. The median age of onset for melanoma is age 65. It occurs in males and females equally. It's actually quite rare in darker skinned individuals, more common in the kind of people that we see here in Minnesota, as far as predominantly in the Northern European type race, and it is something that is obviously we want to get to right away if we see it. So the exact cause of melanomas is not quite clear, but what is known is that ultraviolet radiation from sunlight or tanning beds increases the risk of developing melanoma. Of interest, 15 to 30% of all melanomas occurred on the head and neck. One thing about melanoma, before we get to this slide, is just any melanoma that is on your head, that is covered by your hair, is typically not going to be seen unless somebody's obviously cutting your hair. They have a better chance, or if they actually go to a physician and have a skin check, the physician will usually go through the scalp. But how do we recognize melanoma? What is it that makes melanoma different than a normal mole? So in this slide here, you can see on the left is the benign lesion, and on the right is all the malignant lesions. So in melanoma, it's the ABCDE rule. A is for asymmetry, B is for border, C is for color, D diameter, and E is evolving, or is it changing over time. So let's just go through this one at a time, and let's start with asymmetry. If you look on the benign lesion, you'll notice that the border has got a very consistent edge to it. And if you were to draw a line through the middle of it, it's got symmetry. So if you were like a circle, if you draw a line through the circle, you could fold the circle on itself. On the malignant lesion to the right, if you draw a line through that mole, the two halves don't match. So it doesn't have symmetry. There's something about this that obviously it looks a little bit different than the one on the right, but there's this area on the right of the malignant mole where it looks like it's starting to spread out into the skin. That is a warning sign for melanoma, and in fact that is melanoma, and that's something that we'd want to have to be seen by a physician rather quickly. If you go to B for the border, a border on the benign mole is very smooth. But if you look at the border on the malignant growth to the right, you can see that the border is undulating. It's not very consistent. It's got notches in it. Again, this is melanoma. It's something that should be looked at very quickly. C for color. If you look at the consistency of the color for the benign mole, you can see it's all one color. And if we were looking at moles earlier, it can be dark, it can be light brown, it can be red. As in the one you have a red mole on the top of this page here. So color, just the depth of the color isn't necessarily an indication of whether it's melanoma, But if you look to the right on the color, you look at how it's got differences in colors. And it's the variety of coloration within one mole that makes it concerning for melanoma. So diameter for D, you'll notice that benign moles usually have a smaller diameter than malignant ones. And this is going to be a little bit difficult to assess. Obviously, if they have a very large growth, you're going to probably be saying something to them. But usually, if we're talking about moles that are in, several millimeters versus maybe, 4 millimeters versus 6 millimeters, it's going to be really difficult to actually make the recommendation, or are you going to be even able to notice that this mole is increased in diameter. And evolving for E, moles that change over time are something that we want to be concerned about. Again, that's going to be difficult for you to assess unless you have a client, a long-standing client, that you're seeing on a weekly or month, or not a weekly. If you see them a weekly, it'd be a great client, I'm sure. But on a monthly basis, if you're seeing them and you notice that they have a mole that's starting to change over time, then obviously you would be able to recognize that and let them know that. Primarily for what you're going to be concerned about would probably be the A, B's, and C's, because you're going to notice if there's a mole that has asymmetry, the border is inconsistent, and the color is varied throughout the lesion. So let's review the A, B, C, D, E's of melanoma and let's compare them with pictures that you probably have already seen in the pretest and look at them in comparison with normal moles. If you look at the mole that's in the larger picture, that's melanoma. And if you look at the A, we can see that it's asymmetric. It's really difficult to draw a line through that and fold it onto itself. The border is irregular, and the color is not consistent. We have dark black areas all the way into red areas. In comparison, if you look at the mole that's on the top right corner, it has symmetry. If we were to draw a line, we could fold it over. Its border is regular, and its color is pretty consistent. Even though it's very dark, again, a really dark mole is not concerning. In this picture, once again, in the center, the larger picture, we have a picture of melanoma. Again, if you were to draw a line through it, it's a little bit more symmetric than the growth that we saw before because this is earlier on in this growth. But again, there is asymmetry. And there's an irregular border. Again, you have notches, and it's not a round circle. In comparison, the picture that's in the top right, if you drew a line through it, we can easily fold this over on top of each other, and it has a regular border. Another picture of melanoma in the larger picture, you can see variation in color. The border is not regular, it's asymmetrical. In comparison to the normal picture in the top right, again, we have symmetry, we have a regular border, and the color is consistent throughout the lesion. And once again, we have two dark moles, but the one in the larger picture is melanoma. Again, the border has got notches in it. It's not symmetric. The color is it's not completely inconsistent, but it's also not consistent. Whereas in the top right-hand corner, we have symmetry, we have a regular border, and the color is consistent throughout the lesion. So again, the one on the top right-hand corner is normal. The one in the larger picture is melanoma. So let's talk about diameter. You may notice a lesion with a really large diameter, and if the lesion has been there for a long time, it's usually not something that's of concern. If it's something that you say, hey, you had a large mole on your head, and most people will know if they've had it for a period of time. If they say, what are you talking about? Then it's probably something that's changed recently, and it's something that they probably should have looked at by a dermatologist. The evolution of a mole is probably something that is you as the hairdresser are best able to diagnose. If there's a mole that you've noticed or something that you've noticed on somebody's head and it's a long-standing client of yours and you've noticed that it started to change, then you should be saying something. Again, I think of it as the elephant in the room. You have the ability to not say something, but you can also do something. And if you may be the only one that notices, so if you do see something that's changing, then definitely say something. They should have that looked at by their primary care provider, who will then refer them on probably to have it be seen by a dermatologist. So just going back to the pictures that we just looked at for referral for melanoma. Melanoma is the most serious form of skin cancer. A client with a skin lesion concerning for melanoma should be made aware of this, and it is important that they see their doctor in a timely fashion. This is one of those things that if you catch it quickly, you can cut it off your body, and you have a very good prognosis. If it stays on your body for any period of time, the rate of metastasis is quite high, and it's very poor prognosis if you have metastatic melanoma. We're also going to talk about some other skin lesions now that should probably be referred, some of them not, but there's not the immediacy of when you see melanoma, but we should be aware that these are also, some of them can be concerning, and some of them look an awful lot like melanoma. So the first one we'll start here is with cutaneous horn. You may have not seen this, but if you do, you'll absolutely recognize it. It's usually very scaly. They do look like horns. They can become cancers. They should be recommended for referral. But if you see this, you're probably going to say something. Actinic keratosis is something that's very common in the elderly. It is directly related to the amount of UV radiation that a person is exposed to throughout their life, or through the amount of sun exposure that they have. It usually is crusty, scaly skin. It's people that are losing their hair, or the elderly, on the sides of their face. It can be precancerous. In fact, about 10% of actinic keratosis advances to squamous cell carcinoma, which we'll get to in a second. But not all of these are cancerous. But I would recommend that if you see something like this, to say, have you been seen your primary care provider about this? You may just, especially if you see quite a bit of it that's bleeding up on the top of the scalp. That is an area that you might want to say you probably should have your primary care provider or dermatologist take a look at it. Squamous cell carcinoma is a cancer, but it's a very slow-growing cancer. It should be definitely looked at, but it's not something to the level of melanoma. It's very common in sun exposure. Again, actinic keratosis, which we just talked about, is a precursor to squamous cell. But typically, if you get to the level of squamous cell, you're going to start, as you see in the picture on the right, you're going to start to see a bloody, crusty type appearance. And it will probably be something that you would probably, even if without this training, you would probably say, hey, you might want to have this looked at. These do grow very slowly over many years, but again, it's something that would need to be biopsied and something that would need to be removed from the body. Basal cell carcinoma is actually the most common form of cancer in humans. In fact, it's so common that they don't even keep statistics on it anymore. It's dome-shaped, as you can see in the picture. It's with rolled edges. You may have small blood vessels that are called telangiectasias throughout it. They're very slow-growing. They do need to be referred, but they're very slow-growing. They rarely metastasize, and they're usually not all that dangerous. Now let's talk about going back to nevus just as a review. A nevus is a mole. Most moles are benign and they're not cancerous. You do not need to recommend for follow-up on a mole. So as we can see here, these are the blue nevi that we had seen before. And again, they look really dark. You may think that looks like melanoma, but once again, going back to our ABCs, there's symmetry, the borders are consistent, and the color is all consistent. Again, more nevi. This is something that if you saw something on the scalp like you see in the top right-hand picture, you may say, hey, you got a pretty sizable mole here. And they may say, oh yeah, you know what, I've known about that for a long time. If it's been there for a long time and it's not changing, then it's probably not something that we need to be concerned about. Again, moles can be raised, and that's not something for concern. It's important if they were to be raised and started to change, then that would be something that we'd want to have a physician look at a little bit closer. Cherry angiomas are something that actually are a little bit tricky because they can be red, they can look like they're bleeding, and they are often something that is associated with the elderly. However, they are benign and they don't need to be referred. They do look a lot like a bleeding squamous cell or a bleeding, well, they look like bleeding squamous cells mainly, but they can also look like a basal cell. But these are a little bit tricky, and don't be, if you make the referral and they come back and say it was just a cherry angioma, this is something that would be tricky for a healthcare provider to recognize as well. Dermatofibromas are actually something that look a lot like melanoma if they have the right growth on them because they are not consistent color. Again, they are benign. They're firm nodules that arise from the skin, usually on the lower legs. You can see them on the scalp, but not as often. They can also arise after an area has been, you've had trauma, a rose thorn prick, or if you get a bug bite. Again, they're benign. There's no need for referral of them. But again, these are going to be a little bit tricky because if you look at the color of these, the color is inconsistent. Seborrheic keratosis are something that look a lot like melanoma, and people are often very confused by this. They are growths that usually are asymmetric, which fits our ABCDs. They color can be inconsistent, and the borders are not consistent as well. So you would think, well, how do we determine whether or not this is melanoma? The difference with a seborrheic keratosis is that they usually look like they are stuck on. And if you look at the top right picture, I know it's a picture, so it's a little bit more difficult to see, but this does look like a stuck-on growth. And if you were to look at this person, it looks like something you could take your fingernails and scrape off. If it looks like that, it's not melanoma. They also very often have this crusty appearance to them. Again, that's not melanoma as well. Melanoma is usually embedded in the skin, may have some slight raised areas, but typically it's not something that looks like it's stuck onto your skin. These are totally benign, and they can be taken off by a dermatologist, but there's no risk in leaving them on your body. Sebaceous hyperplasia, again, sebaceous glands are the oil-secreting glands in your body. You may see these on older adults. They may be behind the ears, also in the face. It wouldn't be uncommon to see them on the scalp as well. But these are also benign. There's no need for referral on these. This is just a common condition that you see in older adults. Skin tags are something that's seen quite often. Again, they can be on a small stalk. They can be many of them, or it can be just a couple. But they do not need. They're just more. They don't need referral. It's more just of a cosmetic issue for most people. Solitarigo are something that actually looks a lot like melanoma as well. You usually see this in the elderly. A lot of people call them liver spots or age spots, but they just happen. It's the melanoma type cells in the body, but they're not cancerous. So we make sure that this is not a cancer, but that causes over time UV exposure, causes this type of skin discoloration. These do not need to be referred. This is a normal process with aging, and it's not something that, again, you would need to be concerned with, and you would not need to tell your client anything about them. You also can get some growths around the eyelids. They're really just fatty deposits, cholesterol deposits that can grow up around the eyelids. You can also get them in other areas of your body. Again, this is something that may look like it's a tumorous growth, but in fact, there's no need for referral. So in summary, melanoma is the most dangerous skin lesion and occurs commonly in the head and neck. Remember, to figure out whether or not it's melanoma versus some benign growth, look at the ABCDEs. If it's asymmetric, if the border is not consistent, if it's got multiple colors in it, if the diameter is quite large, or if you notice that it's been a growth that's been growing over quite some time and it's really starting to change, then that's something you probably should tell your client, hey, you might want to have this looked at next time you see your primary care provider. Or if it's something you're pretty certain that this is melanoma, then I would say not even the next time you see your provider. I would say you probably should have this seen earlier rather than later, just to make sure that it's not melanoma. Again, the best treatment outcomes for melanoma come with very early detection and early intervention. You can play an important role in identifying lesions that are suspicious for melanoma, because a lot of the lesions that are covered by hair, there are very few people that actually are going to look at them to make sure and look underneath the hair to see if there's something suspicious there. Again, thank you for spending the time to learn about this. We hope this presentation has made you more comfortable in recognizing it. It's a real simple process. Remember those ABCDEs. And again, hopefully you feel comfortable in suggesting a client referral if you see something that looks suspicious.